growing weary of running from room to room, practicing one-tooth insurance-driven dentistry? Then stay tuned for the latest episode of The Lionhearted, where Dr. Stephen Rasner will hand you the blueprint for what many call the gold standard of general practice dentistry.
Hi everyone, Dr. Steve Rasner here, and you're listening to The Lionhearted Dentist. Those of us that still hold the dream that we can practice the way we want to practice on our terms, be our own boss, or be in a group practice that is independent of insurance or mostly independent of insurance. That's what we stand for, and that's what these podcasts are about. Last week, I started out the podcast by telling you about a Facebook post I had made. And I do want to remind you, I'd love some of you to be my Facebook friends, where I post a lot of similar information that you hear on the Lionhearted. And so it's Stephen L. Rasner, DMD. And just go to Facebook, put me in search, ask me to befriend you, and I'm right there. And it led to a pretty interesting talk last week where I was talking about a 39-year patient of mine who's now 87 years old, and how it kind of brought all this philosophy back together for me. Like what I go into each and every week with you, and how he exemplified exactly what we go for. He was no pushover, trust me. And when I say that to you, what I mean is you have 3 to 4 different types of patients. You have that one patient that's just a blessing. They are a pushover. They'll do whatever you recommend. I need a root canal. Sure, you're the doctor. Money is almost never an issue. They also often don't have a myriad of problems to solve. But whatever it's been over the years, they come to hygiene religiously. I mean, it's just a beautiful thing. And then we have that segment that we'll take the other end, that never do anything. They kind of fall in and out of your office. Sometimes they're gone for 5 or more years. And they believe in you. They trust you. They just have not prioritized their mouths. And I keep them in my practice as long as they don't violate what you keep hearing me talk about as lines in the sand. And then there's the middle category. And there are patients who half buy in. They'll do some of your work, but they don't replace every missing tooth, of course, and very few patients of mine ever do that. Of course, it depends on how many teeth they have missing, just like yours. My point is that we all have multiple different types of patients, and that's not the focus of this particular podcast. I will tell you that it's important that you keep that nucleus of patient base as large as possible and as trusting as possible. That your goal in your mind each and every day is that even if patients leave your office without a commitment to care, they do not leave with a bad taste in their mouth because of something you or your team did. Did you talk down to them? Did you belittle them inadvertently? I know you didn't do it on purpose. Did you make them feel not value? All of those would be unacceptable. What would be acceptable, saying it in the proper tone of voice, without saying it with an inflammatory attitude to it, would be a line in the sand of your philosophy of care that they crossed. And I've shared this with you many times and told you that if somebody comes in and says, can't you just clean me normal? And they have periodontal disease. I don't mean marginal periodontal disease. I mean pocketing over 4 or 5 millimeters, bleeding upon probing, edematous, puffy, purple, everything you know. No, I'm not going to clean them normally. I'm not. And I'm not going to be mean about it. I'm going to be proactive. I'm going to give them as much time as I give the next patient who buys all in. And I would even encourage them to get a second opinion. I don't know about you, but I'm pretty sure this is going to be true for you. It feels good when you've spoken your mind, when you've done the right thing to a patient. And even if that does not result in treatment. And it's kind of hard at times. I mean, maybe that patient comes into you, in their mind, they broke a tooth, and they've even agreed to a crown, a single crown, and you're having a crappy week. So even one crown and the core buildup and whatever else goes along with that sounds somewhat good on that given week that I'm giving you an example of. And you really don't want to say no to that. Are you going to overlook a foundation principle of that patient's care? I wouldn't. By the same token, I don't feel compelled to retreat every root canal that has a suspicious lesion, even though they had root canal on it. They are informed of it. They know it's asymptomatic, by the way. I mean, I have tons of examples where I can't treat all the pathology that I am diagnosing because I have a patient that just doesn't have that kind of pocketbook. And I would gladly get into debate with anybody listening to me, on stage, by the way, in front of as many dentists as you want, on this type of approach to patients. Where do we draw the line? It's pretty good talk. You know, where do we draw the line on what we're okay with, and we will proceed with something. I had a patient in today, full dentition, crowns in his mouth. I didn't do them. Not perfect, but no perio disease. Certainly little bits of inflammation, localized, secondary, by the way, to some of the restorations he's had. And he had a little minor fracture of a composite exposing the lingual groove. And it was as clean as a whistle around it. Hard dentin. And he just didn't want to do anything with it. Whatever I caught him in today, at this particular moment of this year of his life, he didn't want to deal with it. And I certainly didn't make a big deal about it. But I also alluded last week to the fact that I've gone through a couple week period, and it rarely, if ever, goes past 2 weeks, by the way, because I start breaking down the house. I'm not kidding. I mean, I can put up with 1 week that's off 30% or more. I start looking around. What aren't we doing that we normally do? How's recall been? Do you have somebody regularly doing that? Because I have 2 people that I pay them to do that, by the way. And that's in another podcast. I've tried every other angle you can have to try to get my staff members to constantly hammer recall. It's an ugly job. Picking up the phone and calling 50 people over a period of 2 days, of which haven't been in your office in 6 months. And sometimes the reply you hear isn't fun. Oh, you messed up my billing. Oh, you told me this, you told me that. I would love to sit here and tell you guys that I practice in heaven and that I never have these issues that I just alluded to. But I do. Even I try so hard to appease my patients because it's how I'm built. It does bother me. Even 39 years after being in practice, it bothers me. Really bothers me when a patient leaves me. Certainly if they've been with me a long time. It does. I wish I wasn't like that, but I am. So recall is a very, very challenging job in the office and very, to most people, not rewarding. And I literally pay, well, you'd have to write me for me to tell you this, but I pay a fee for every patient recalled that actually steps foot back into practice. And by the way, they're usually tremendous patients. Recall patients are almost better than new patients because they know what you're about. They know your philosophy of care. They know your fees if you're on the high side, which I am. It's a good investment from my point of view. So I'm getting, I know, I'm famous. I should call this podcast the Go Off Track Podcast. I should rename it. I know I'm going to go off track podcast. That should be the name of my whole thing. I can't help myself because when I'm working and I'm so excited to share with you different thoughts that I think that you need to hear that are relevant to making your practice better. So what I'm doing right now, I have a litmus test of about a week. And if things are off, I start looking at everything. Recall, billing. I mean, I get paid up front, but not 100%. And if you're doing several million a year, that little example I just gave you can add up significantly. It can. Are people bringing us back the checks that they get because I'm out of network with insurances? I mean, you got to track everything, but it's worth it, guys. It is, man. You know, I encourage you to write me at drrasner@aol.com. And if you have any specifics, you want me to talk about something, you want to ask me a question, I'll even call you. Sometimes it takes me a while to get back to you. But that being said, I was talking a few minutes ago, as I was last week, that I ran into a slump. And I was giving you examples. And I'm going to give you some more. Because sometimes, even when you do everything right, and when I say that to you, you have the cornerstones in place. And I've called these cornerstones lots of different words with you over this last year and a half. But to me, they're, are you trained? Are you educated at the top of your game for the services that you provide? I'm in this now almost 4 decades. I'm taking a stinking endo course in a month. And I haven't taken an endo course in years. I stopped doing endo. Because first of all, I walk my talk. Most of my practice is surgery and preparations for implants, implant placement, implant restorations, and heavy-duty restorative work, crown and bridge in patients who can't have implants or don't need them. That is what I do. But when I realized, just from being an enthusiastic member of dentistry, that the treatment of endo has gotten a lot easier with the rotary endodontics, that I started using rotary endodontics just by reading, YouTubing, and stuff like that. And so I'm actually taking my first endo course in probably 20 years in the middle of April. Just a 1-day course. I don't do molars. I don't have the time to do everything, but it does seem to be a practice benefit for my patients. I don't do it even for the money. By that I mean to keep it in-house. It's not why I do it. And by the way, I send my molar endos to an endodontist, pay him full boat, because I can't find anybody as good as him. And I find it really a conflict of interest for those of you, if you did what I did, and for years you have an endodontist in-house, and you know in your heart the endo's okay, sometimes really good, but other times average, when it could always be amazing. How does that jive with the rest of your work if you're always aspiring to amazing? You're going to compromise that very big part of dental health because you're going to keep it in-house? I think that needs to be rethought. I rethunk it. So, education. I took an amazing, and please write to me if you want some of these courses. Course on harvesting bone. I was told over the years and years that the tuberosity bone was not the greatest bone to use to harvest to do bone regeneration. Well, then I took a course about a month ago from a doctor from Brazil named Dr. Carlos Rosa. Some of you might know him. I didn't know him. You can't take everything. And I spent 3 days learning amazing. I bought the kit that he advocated, and I've already employed his concept, which is amazing. Look it up. Carlos de Rosa, IDR. Google it. It is amazing. It's immediate dentoalveolar reconstruction of sockets. He takes sockets you would never dream of treating. I would have told you to extract the tooth, socket graft it, and come back in 16 weeks. And I still do that in most of the cases. But he changed my paradigm. He did. And if nothing else, I frequently now go to the tuberosity, which often has way more bone than you think it has. You need a CBCT scan for sure, which you need with all these kind of surgeries. But it's astonishing. And by the way, it's much easier access and an easier harvest than going and laying a flap and doing a ramus graft. And I think the morbidity is significantly less. I used the tuberosity in the past, but not to get blocks of bone that I now screw in. It's blowing me away. I mean, you hear me, man. I love learning. And so, yeah, education is a big cornerstone of what I think you need to do. Having the right team. I mean, that's a constant battle for me. Do I have the right team? I want to always have the right team. And sometimes we just slide into these weird spaces where we keep people that we know really aren't the best people on our team. But sometimes you got to just say, how bad do you want this? This that I'm alluding to is having a week or several weeks out of the month, if not all of them, where you're very self-satisfied with the work that you provided for people. That you have people that are very appreciative. They paid you top dollar under my philosophy of care. My philosophy of care has never been lowball your fees and lots of people will come to you. That is not the podcast that this is. That's somebody else's podcast. And my podcast is about having a team that understands that the work you're providing requires ample time with these patients. For me and for you, exiting them out of the front desk when they're done, or we're entering them into the office when they come in and doing it and making them feel value. You just can't be this great clinician. You got to have a team. That's a cornerstone. Branding. What do you stand for? You branding that you're open till 9 o'clock at night? Well, you do have to do that sometimes, especially if you're just starting. You don't have to apologize to anybody either for doing whatever you got to do in those first 5 years, or whatever it takes you to get that community to know that you're special. That's right. But certainly later in life, I'm branding, we don't hurt and you can trust me. And we sedate you. That's my whole message in a lot of different angles, in a lot of different ways. If you have that cornerstone in place. And then, of course, to me, the moment of truth is always, how good are you? How good are you when you walk into that treatment room with that new patient you're about to meet for the first time? How good are your skills? How good are you at looking people in the eye? How good are you at looking good as you can look in the mirror so you look fresh, trusting, not rushed? How good are you at being sincere and passionate and honest and not pressured that you need that case, even if you do need the case for a good week or a good day? How good are you at not letting that creep into that case presentation? This is important stuff, man. I'm dead on with this. And even when you do all that, you get a couple patients like I had this week. I had this 72-year-old knocked out looking woman dressed to the nines and said to my new patient coordinator before I met her that we do one-to-one interviews in the office before I even get to them. Even though she did it on the phone just a few days ago or a couple weeks ago when she made the appointment. We do another one-to-one interview in the office. And why would I do that? Because people often don't tell you the truth on the first call. They're either in denial. I don't know why they don't do it. But when they're in your office, they often let their guard down. And even though they told you on the phone, no, I just have this one broken tooth, I'm good everywhere else. And then you walk in and you have periodontal buzzard breath in the room when you walk in there. They just have an unbelievable amount of dental pathology. So that's why we do the one-to-one interview in the office. And I finally walk into that room, and I did that with this woman. And while she was doing that interview, she mentioned that she was missing multiple restorations, and she wanted to fix everything. I mean, I just don't get these that often. I don't. And I walk in, and I spent a lot of time with her. And she was an easy diagnosis and treatment plan. She had very little periodontal issues. That's always my number one examination. And she was literally missing multiple crown and bridge in her mouth. But get this, on abutments that were fine. They had good bone. They did not have decay, except for one. She was missing an upper left bridge, a lower left bridge, 4 units each, lower right, 2 crowns, a 2-unit splint. Only one of the abutments out of all those teeth was not satisfactory. And when I teach doctors about atraumatic extractions, I always say this: listen to the tooth and it'll tell you what to do. So if you're leveraging a tooth right and left, which I would never teach you, with a forceps, and it's not moving, it's telling you to do something else. You're just not listening. Or if you're using an elevator and you're trying to move the tooth distally, based on some principles I've shared with you, and it's really not moving a lot, either you haven't held the fulcrum for the 10 seconds I tell you to hold it, or you haven't troughed in between the roots enough to gain leverage to move the tooth, to move the root. And guess what? If you look at the mouth and listen to the history of the mouth, it will also talk to you and tell you what to do. So when I look at a woman with crown and bridge, which is not my favorite number one go-to to replace teeth, as you know, it worked in her mouth for years and years, with the exception that it's missing. It's not like they were missing on top of a sea of decayed abutments and periodontal inflammation. It was bizarre. It was almost like she lost her temporary crowns. So the treatment was easy. I was going to replicate what she had. I was going to build up the abutments better than they had been. She was starting to enter a world of collapsed vertical dimension. As you can imagine, she only had her anterior 6 teeth, maxillary and mandibular. And she was starting to get spacing on 8 and 9. And she wanted that fixed too, by the way. Guess what? And I try to do the most conservative treatment. So I could have justified, well, why replace the bridge with a bridge? Why shouldn't I recommended putting an implant in the tooth that the bridge replaced? Because what she had worked. I don't consider the fact that the bridge wasn't in her mouth as not working. Not working to me would be failed abutments, inflammation everywhere, compromised bone on the abutments. That's not what I was seeing. And we get to the money, and she had no money. Nothing. Like, I don't even know how... What do you go to the store like that too? I mean, I spent an hour of my time. In the old days, before HIPAA, we would do financial applications over the phone. You can't do that anymore. It's not allowed. And so I haven't figured out, without being too egregious or too aggressive, how to get to that any sooner. I had faith in her, that she had good intention and goodwill, and I don't know what she was thinking. So that's one case during this slump. Sometimes things happen, you just can't prepare for. That's the name of the game. But I never panic. And it's not because I have 50 million in the bank. I've been in this long enough. This is important for you to hear. That I know if I continue to do what I'm sharing with you each and every week, at the end of the year, the good days outweigh the bad days by far. And I end up with a good year. I once had 29 years in a row of increased growth and profitability. I had 3 bad years in a row from 2009, 10, and 11. The only time in my career that happened. And that's just doing what I'm sharing with you every week. It works, guys. It absolutely works. But I want to give you one more case before I leave this week. So check this one out, because I think maybe you should remember it. This patient walks in. I could tell he did have means. How do I know that? I don't know for a fact, but I never got to find out. But just hear me out. And I know his history because I make it a point to know their history. And he had dentures for 50 years. He was in his 70s. And he's one of those patients that loves his dentures. He just wants his teeth sharper. I'm kidding you not. He had no mandibular ridge. And he didn't use adhesive. His occlusion was class 1. Perfect. He did not have a pseudo class 3. His anterior teeth looked pretty good. His posteriors were kind of worn. Very worn. You know what I said to him? And he didn't want to hear anything about implants. He didn't. He made it clear. And he seemed like the type of patient that had plenty of money, that was just getting ready to be sold again. I didn't really delve into how many dentists he saw before me. I told him the truth, and I'm telling you the truth. I said, when I have a patient like you that could actually, seems to me like you're thriving on a condition I can't explain. You're thriving without any bone. I'll be damned if I'm going to make you another denture. I'll tell you the only thing I would do, and that's up to you. I would change your teeth on this denture. I wouldn't even reline it if I was you. And I didn't. And I didn't care, and I told him. I didn't particularly like this guy. He did it. He went for it. I said, I don't really care whether you do it or not. I'm just telling you what I would do. I mean, would I love to see you with an implant retained denture so that you really know what you... He told me he can eat steak. So either he's lying as the cheapest SOB on the planet and will even lie for that, or he's telling me the truth. And I have a feeling he was telling me the truth, and his wife was sitting right next to him the whole time. What did I get from that? I did the right thing, in my opinion. And what I told him when he left is, hey, if you like how this works out, tell your friends about me. I'm not going anywhere. I'm telling you, there's a guy that I established trust with. I mean, there's a lot of out-of-box thinking all the time. And you got to remember, during this slump that I've told you about, which in a lot of offices wouldn't be a slump, I was doing significant crown and bridge on those patients that did say yes and did have monetary means for what I recommended. And I did try to be conservative with many of those patients. And by the way, he doesn't even know I'm saying this, but look up Strupp Blum in Facebook. Strupp Blum. They have like 7,000 members already. And Strupp is one of my original mentors. And it's the opposite of my fascination with implant dentistry. It's saving teeth that you don't think could be saved by using his protocols of core buildups very stringently the way he does them. And he gives a lot of this information away for free on Facebook. And he gives a course 2 times a year, one in Florida and one in San Diego. That's Bill Strupp and Mike Brum. Google it or write to me if you can't find it. It's just the opposite side and would help a lot of you. I hope I'm helping you. Thanks for listening. I'll see you next week on the Lionhearted.